This is Elliot Fishman, and welcome to our latest Facebook Live. I know it's 10:30, so for many of you around the world, and I know on Facebook, believe it or not, that 80% of our users are non-North America. So for many people, it's in the evening, so this will be a little bit earlier. Our friends in Australia, I think it's 12 hours, so it's probably, it's late, 10:30 at night, but it's not like 2 in the morning. And the rest of our friends in Europe, Middle East, so we'll say hi as well. So this talk will be on the stomach, and actually we've been putting this off for a few weeks because we were supposed to do it a couple weeks ago, and we had the honor of having Reed Jobs come visit us, and then Stephanie Greenberg with Josephine, who's a dog that's trained to deal with patients. We thought that was very important. And so now let's talk about the stomach. I actually was working a bunch on the stomach. We have an exhibit, myself, Linda Chu, and Steve Rowe, that I finished up this weekend when I was in California. Santa Monica for a couple of days, and I did this really, we did it on cinematic rendering and how you can use cinematic rendering for evaluation of gastric pathology, both for tumors as well as for inflammatory disease. And that exhibit, I think, will be really nice, beautiful images, and we have a lot of good results in terms of how you can use it in terms of staging, looking at infiltration, linitis plastica, separating gastritis versus cancer, staging cancer perhaps better. And we've published before a number of things over the years on 3D imaging in general for the stomach, which can be very helpful, but I think the cinematic has certain advantages, and I think the exhibit will show that nicely. There was an article last year, I think Steve Rowe was the first author on the cinematic rendering of the stomach, and that was in JCAT, so maybe something you might want to look up. In the stomach in general, forgetting the 3D imaging for a moment, the key thing to me about evaluating the stomach is gastric distension. And whether you're using positive and neutral contrast, each have certain advantages perhaps. The key thing is that the stomach is not distended. You always have an issue. Is it pathology or is it under distension? And you kind of fumble around a lot. You can look at enhancement patterns and things like that. But at the end of the day, technique is everything. So we like to give 1,000 cc's of fluid before we do the study. The last 250 when the patient gets on the table. I always tell the techs that no one ever got yelled at for giving too much oral contrast. So if you think they drank it, but you're not sure, just drink more. You just can't mess around. Again, oral contrast becomes your friend. I make this point because now in the ER setting, many places that ER docs don't want to give oral contrast. They don't want to give IV either, but they certainly don't want to give oral. My point is, when you're doing somebody with abdominal pain, gastric ulcer, we had a case last week of a gastric perforation. Gastric disease is very common. And so you want to pick up infiltration by tumor in older patients. You want to pick up gastritis. You want to pick up ulcerations. You want to pick up many of the things we can think about in the stomach as a cause of abdominal pain, including ulcer disease. But if the stomach's not distended, there's no way you can call it. So if I look at reports, the reports typically say stomach undistended, cannot evaluate. Advise clinical correlation of further study if warranted. Repeat CT if necessary or do endoscopy. Or you end up saying the stomach probably is normal, but I can't tell because it's not distended, or possibly abnormal, but I can't be certain because maybe it's lack of distension. All of those could be this, could be that, could be eliminated. Just give the patient water to drink. If you want to use positive contrast, oral Omnipaque, it's in preset bottles, this big, 500 cc's. Even 500 cc's is wonderful. Now, I do like when I'm looking at mucosa, water as a contrast agent, but looking for perforation, positive contrast is better. And positive contrast is very good in the ER setting. Again, it travels fairly quickly. But surely anything in the upper stomach or anything in the stomach in general, duodenum, jejunum, is going to be well opacified. No, we're not waiting 2 hours or 3 hours like the old days, though at Hopkins we never had any old days. But with a positive contrast, you're going to get a great look, even if you wait 2 minutes of the stomach and the small bowel proximally. There is really no excuse. The patients are happy to drink it. If you use water, patients are always thirsty. It's low cost. It's easy to do. There's no complications. Patients aren't going to aspirate. Use positive contrast and use the oral Omni. If they aspirate it, it would not be a problem, but the people aren't aspirating. And we're not saying give oral contrast to patients who are at risk of aspirating. That's a whole nother story, a whole nother tale. We're talking about the routine patients. And so this is in the ER setting, but it's also across the board. You just need to make certain you give patients contrast to distended stomach. Now, once the stomach is distended, I'm in business. So now I can look at wall thickening. We also look at enhancement with IV contrast. The gastric wall, we used to talk about a centimeter, but I say above 5 to 7 millimeters is thickened. We look at the symmetry of enhancement. We look for irregularity. Axial views are okay, but axial view, in a sense, always has partial averaging. So what I like to use is coronal display, especially. Coronals are really good. And coronal volume rendering is particularly good for looking at the fold pattern and thickening and ulceration. Sagittal views are okay. Sometimes I do a sagittal or an oblique sagittal when a patient has what looks like obstruction in the antrum or proximal duodenum. Looking at the axials doesn't help typically, and looking at the coronals, things are cutting back, doesn't help, even if you scroll. But the right sagittal plane works perfect, and I can see transitions in the duodenum, transitions in the antrum, and I can see any pathology. So again, the thing to remember is that the reconstructions are your friend. You don't want to be sitting just with the axial imaging. I think that's going to be a challenge for you, and it's definitely a way of making mistakes. So I think I want to be more careful about that and look at all of the planes. Now, in terms of wall thickening, I mentioned above 5 to 7 millimeters. I think it's abnormal. We talk about focal abnormalities in the stomach and diffuse abnormalities. You can have diffuse abnormalities or focal in gastritis. You can have tumors that are focal. Remember, most adenocarcinomas tend to be focal, polypoid, often intraluminal. We talk about lesions that are intraluminal as well as lesions that are extraluminal. The extraluminal one we typically think about are GIST tumors, gastrointestinal stromal tumors, very large, homogeneous, can measure 15 centimeters, and typically are in the 5 to 10 centimeter range in the stomach. GIST tumors can perforate, they can ulcerate. Remember, GIST tumors are treated with Gleevec. The intraluminal ones are less common. The extraluminal, the exophytic ones, are more common. And I've seen them range from 1 centimeter to 20 centimeters. The smaller ones are typically easier to diagnose. Most of them are easy to diagnose. What I was going to mean is that sometimes the very large ones are more difficult to diagnose. Not that you don't see them, but sometimes whether it's liver or spleen or it's pancreas or retroperitoneum and simply abutting the stomach is something which can be a bit tricky. Usually I can figure it out, and I think you can figure it out as well. But you always want to be careful, and I always do make the point that the largest masses are often the most difficult. I've seen a couple of cases, we were going to do a quiz on one, where the masses are so exophytic and they butt the pancreas that sometimes it looks like a pancreatic mass because it's compressing the pancreas. I've seen it also invade the pancreas. So sometimes it's really tricky. You're uncertain, is this a mass coming off the pancreas like a SPEN, a neuroendocrine tumor or something like that, or is it a GIST of the stomach? It can be somewhat tricky. Usually with the recons, you can come up with the right diagnosis. So I'm not that concerned about making that mistake. Those lesions are also coming out. If you theoretically did make a mistake, they're not going to do a distal pancreatectomy till they examine the patient. So in those cases, you can see whether something is indeed at surgery, stomach, or pancreas. But I think we should be good enough to make that diagnosis. It becomes important, of course, if you think it's stomach. They are going to use Gleevec before they operate in most cases. So you want to make certain the right sequence is being done for your patient. So that becomes very important. Now, what else about the stomach? We talk about carcinoma. We think about focal thickening over a centimeter, often irregular, sometimes enhancing a bit. Think of adenocarcinoma. We think of nodes locally, right? You want to think of the celiac, the SMA, portal cable nodes, and peripancreatic nodes. These tumors can spread to nodes, and we talk about a node over 8 or 9 millimeters being considered positive. We talk about the fact that the patient's nodes can be bulky, and at times adenocarcinoma can look very similar to a process like lymphoma. Typically, the point always was lymphoma is bulkier, though we pick up lymphoma earlier, so it's not the 5 centimeter wall thickening we saw in the old days. You also look for nodes, and the rule typically was, and probably still is, lymphoma has bulkier nodes than gastric adenocarcinoma, but lymphoma also has the nodes extend beneath the renal hilum, and with adenocarcinoma, typically stops by the renal hilum. That can be helpful, so bulky nodes, you got to be thinking about lymphoma. We also talk about spread. We look at the omentum, the gastrohepatic ligament. We realize tumors can spread up the gastrohepatic ligament and down them. We realize that the stomach is contiguous with the abdomen because of things like the gastrocolic ligament, and so spread of tumor and then to the colic zones are also indeed very possible. We talk about gastric cancer as a tumor that spreads into the peritoneal cavity. It goes to liver, it goes to nodes locally, it goes to ovary, remember so-called Krukenberg tumors. Sometimes you have a strange case with ovarian masses, particularly when it's unilateral and a gastric mass, and you say, is this gastric cancer going to the ovary, or is it ovarian cancer going to the stomach? Remember, on implants, ovarian cancer goes to liver and stomach and spleen because it spreads around. But again, gastric can go to ovary. So it's a lot of different possibilities. And these tumors are very kind of dynamic. They change over time. Some people respond to therapy really well. CT is used very nicely in therapy and therapy planning. So that works very nicely. We are looking at things like deep learning, AI, and radiomics for doing just tumors and predicting high grade versus low grade. And this is not important with bigger tumors that are going to be resected, but we pick up a lot of 1 to 2 centimeter just tumors, sometimes with calcification, and you wonder, does everything need to be resected or can it be followed? That's a great question. You might be able to follow them, and if they had a low mitosis rate, that may be the way to do it. So again, it's something that's in a sense a work in progress. What are we looking at? In terms of looking at the stomach, in primary gastric masses, you kind of also need to think about metastasis. We've seen direct invasion by the pancreas, and I guess that's metastatic disease by direct invasion. But typically what I think about are implants. So when you have patients with gastric cancer, implants and omentum and mesentery, ovary we think about, but other tumors go to stomach, like ovary goes to stomach, pancreatic cancer directly involves the stomach. So there are a number of processes, and so I try to look at the entire process. Again, you're more likely to have a primary gastric lesion. We also talk about patients with linitis plastica. Patients with breast cancer, a classic location breast cancer goes is actually to the stomach. You have a diffuse, the stomach looks like it's collapsed and it's not thickened, though you know you gave enough oral contrast. That's really the key. The stomach just has thickened walls and a decreased lumen volume, and it's called linitis plastica, which means infiltration. And you can have linitis plastica for a number of things, including primary gastric adenocarcinoma, that we typically associate with metastatic disease, and particularly metastatic breast cancer. We've seen a bunch of patients who recur with breast cancer or having symptoms, and they have linitis plastica. So it's something to be aware of. And if you're doing patients with breast cancer, again, gastric distension is critical. The point being, again, we'll go back to, if the stomach is not distended, you're not certain what's real or what's a pseudo lesion. So you undercall or you overcall depending on what kind of reader you are. But I know there's always times we can make mistakes because we're not certain, but I have to admit the stomach should not be one of the cases. You should be able to have a perfect study without bringing the patient back. And I think this requires careful speaking to the technologists, make sure they're on top of things, make sure they know specifically what's going on. Just in terms of protocols, let me finish up with this. I mentioned gastric distension, 1,000 cc's over 20 to 30 minutes, the last 250 when the patient gets on the table. I want to do IV contrast. I want to do 5 cc's a second of Omni 350. We can get by for many cases with venous phase imaging. If I'm staging a tumor or high suspicion for tumor, I typically will do dual phase imaging so I can get better characterization of tumor nodes and the liver. And then I'll do dual phase. I like reconstructing. 3D works very nicely. It's cinematic, as you'll see, works really well. But at a minimum, you have to be doing coronals, and sagittals can be somewhat helpful. So that's kind of a good way of thinking about it. And that's kind of a good way of thinking about the stomach. If you go on CT as us, I have a lot of new references coming up in the October, the new references. There's a bunch of pearls you can look at. There's a bunch of case studies you can look at. And there's a bunch of really detailed lectures. So that about covers what I can talk about for the stomach. If anyone has any questions, I see Juan Mendoza's online, but I don't see many other people who I know who are online, and I don't see anyone raising their hand or their microphone to ask a question. So I'll counting from 10 backwards like I was an astronaut. And I guess we'll see you next week. And for those of you who are Jewish, like myself, there's a holiday coming up, Rosh Hashanah, the holiest 10 days of the year. Rosh Hashanah is a new year. We pray for ourselves, all our colleagues, all our friends, our family in the world for a happy and healthy new year with peace and prosperity to all. And for those people who are having difficult times, we wish them only the best. And with that, I'll sign off and catch you next time. Bye.